Hello everyone. So today we're going to start off with the next topic, that is pulp therapy. Starting off with, treatment of pulp can be done in two ways. One is the vital pulp therapy and one is the non-vital pulp therapy. In vital pulp therapy, the pulp will be vital, and in non-vital, the pulp is non-vital. Vital pulp therapy is mainly of two kinds you can do. One is pulp capping, in that there is indirect and direct pulp capping, and second is the pulpotomy, in that only the coronal pulp is removed from the pulp canal. In non-vital pulp therapy, there is pulpectomy and apexification. Pulpectomy, there is the complete removal of the pulp. Starting off with indirect pulp therapy, it is a procedure in which a small amount of carious dentine is retained in the deep area of the cavity to avoid pulpal exposure, followed by placement of suitable medicament and restorative material that seals off dentine and encourages pulpal recovery. So basically what this is, that if there is a caries present in a tooth, you will remove all the caries from the tooth, but you will leave a thin layer of the caries there only. On top of that, you will apply the medicament and followed by restoration. Why a tiny layer of the caries is still present or left behind is to avoid pulpal exposure, that is indirect pulp capping. Now, what are the indications? When the patient has mild discomfort, absence of spontaneous pain, large carious lesions where there might be chances of pulpal exposure, absence of lymphadenopathy, normal lamina dura and pedial space, and no abscess. Alright, now what is the clinical procedure? All decay is removed except the one overlying the pulp. Calcium hydroxide, zinc oxide eugenol dressing is applied. Calcium hydroxide is applied because it helps in remineralization, followed by amalgam restoration. That is the basic clinical procedure of IPC or indirect pulp capping. Next, we're going to move on to direct pulp capping. In this, there is placement of medicament or a non-medicated material on a pulp that has been exposed in the course of excavating the last portion of the deep dentinal caries as a result of trauma. In direct pulp capping, mainly what happens is that when you are removing the caries, suppose you are removing this caries, while removing the caries, it becomes so deep that there is exposure of the pulp. So here what they do is they directly apply the medicament on top of the pulpal exposure. There is a mechanical pinpoint pulpal exposure. What are the indications? Pinpoint exposure, bright red pulp, which means that the pulp is healthy. Bleeding must be controllable, and radiographically no PDL widening, no loss of lamina dura. Contraindications: where do we not do direct pulp capping? When the tooth is mobile, when swelling is present, or when you see that internal resorption is present. What is the procedure? You use dry cotton if bleeding is present and calcium hydroxide is placed touching the pulp. After the first 24 hours, you will see a necrotic zone is separated from the healthy pulp tissue by a deep staining basophilic layer. After 14 days, you will see partly calcified fibrous tissue lined by odontoblastic cells and is seen below the calcium potentiate zone. There, in after 14 days, you will see the disappearance of the necrotic zone. Then after 28 days, you will see a clear zone of new dentine formation. What are the ideal requirements of pulp capping agents? It should stimulate reparative dentine formation, maintain pulp vitality, should release fluoride, should be bactericidal or bacteriostatic, it should adhere to the dentine, it should be radio opaque, and it should have a good bactericidal seal. What are the most commonly used capping agents? One is calcium hydroxide, zinc oxide eugenol, corticosteroids, polycarboxylate cements, collagen fibers, biodentine, bioactive glass, MTA, mineral trioxide aggregate. We'll learn about two of the materials in detail. One is calcium hydroxide, one is MTA. Calcium hydroxide is a gold standard material. It is used to stimulate pulp healing and dentine bridge formation. there is one disadvantage with that is tunnel defects. The dentine between the blood and the pulp is not very strong and it contains small voids. Therefore, it decreases the strength of the calcific barrier formed. Therefore, coagulation necrosis of the surface of the pulp can occur. Second is excessive dentine formation, high solubility in oral fluids, and lack of adhesion. These are the disadvantages of calcium hydroxide. Next, we'll move on to mineral trioxide aggregate or MTA. It is non-resorbable, superior marginal adaptation, so slow release of calcium ions. These are some of the advantages of MTA. Now, what is the action of this? It stimulates cytokines and interleucin released from the blood cells, which indicates they actively promote calcific barrier. Okay. What is the composition? It comes in powder and liquid. Liquid is distilled water. Powder is purified Portland cement, a mix of dicalcium silicate, tricalcium silicate, tricalcium aluminate, calcium sulfate, tetracalcium aluminate ferrate, bismuth oxide, and this is added for radio opacity. Why is MTA superior to calcium hydroxide? It forms thicker dentinal bridge, it causes less inflammation, less hyperemia, less pulpal necrosis, and the dentine bridge formation is faster.